What is chemical imbalance?
Either there is a depletion of a particular neurochemical or there is an excess.
Look at mental ailments from the medical lens.
Depression would be more in patients with diabetes. Hypothyroidism and the correlation with depression.
Levels of vitamin B12 and feeling of fatigue and depressive features.
Can I do something which will prevent neurotransmitter imbalance in the future? Right now, I can't say that it's possible.
Neuromodulation intervention, it is increasingly being incorporated in the treatment of mental health conditions like depression, like OCD, auditory hallucinations.
So this is the way the coil functions. You don't feel anything. There is no invasive or electrical activity involved.
You're watching Zen-Brain. What if I told you that depression, anxiety, chronic mood disorders, even mental illness is not your fault? You haven't done anything to get depressed or anxious. Just like it's not someone's choice to get diabetes or hypertension. With this information, ask yourself, why should there be stigma around mental health or mental illness when it's not anyone's fault? We will learn today how genetics, the environment that we've grown up in, which is also incidentally not of our choosing, which Dr. Parikh often refers to as the biopsychosocial model. Do all these factors actually dictate how chemicals or neurotransmitters are released in our brain? What exactly is this chemical imbalance that we speak about? Can we prevent this chemical imbalance, and what are the ways to restore it? And where exactly does lifestyle fit into all this? These are some questions that some of you have put across to us on Zen-Brain regularly. So I'm putting it to our guests today, two psychiatrists, Dr. Samir Parikh and Dr. Shambhavi Jaiman. Thank you both for joining me on Zen-Brain, first of all. Without wasting any time, and I'll throw this open to the both of you, what is chemical imbalance? And is this an oversimplified term, or does it accurately describe mental health disorders? Let's start with you, Dr. Parikh.
I mean, see, it's the way you look at it. I mean, you can say it's oversimplified because it is. At the same time, if we were to understand without the complexities of medical terminologies and some of those aspects, it will also be a good starting point to understand mental illnesses. Because bare minimum, what it does is it tells you it's not in your control. Like any other medical illness, you mentioned diabetes, hypertension, so on and so forth, like any other medical illness, there's something happening in your body, which is the reason why you're having a certain illness. Like any other illness for that matter, your lifestyle does play a part. For example, if let's say you had a blood pressure condition and you are smoking or having alcohol, or let's say you are told to avoid certain kind of diet when you have diabetes, but you still indulge into it. Or if you were to exercise, you are not doing it, your sleep hygiene is not fine, so on and so forth. They do have an impact on the illness, its precipitation, how the course of the illness happens, and treatment. Similarly, the social factors also have a role to play. We can't deny the fact that environment does interact with us, and environment here means people. So there are stresses, there are aspects which have an impact. So when you put this together, the biopsychosocial model becomes what it is. And at the core of it, one will need to understand the biological factors have to be respected, because that's how the treatment also plays, right? Which means the biological treatment is happening, the psychological treatment is happening, the social component, lifestyle is also being addressed. That's how you look at both understanding the illness and, more importantly, treating the illness. And once you understand this aspect, then yes, like I said, I mean, you can say yes, it's a chemical locha as an oversimplification or as a starting point. Shambhavi?
Yeah, I think I agree with that. But in the psychosocial model, biology plays an important role, right? So biology is something which will at some point or the other be there as part of it. So we cannot be focusing on the epigenetics, like we say. It is also the biology, which will include your genetics, which will include the neurotransmitters, the neurochemical pathways, which is very, very important to any mental health condition.
Okay, so now let me put that question to you. What, according to you, is this chemical imbalance that we talk about?
In simple words, when we say that, there's a chemical imbalance, either there is a depletion of a particular neurochemical or there is an excess of a particular neurochemical. It is important that we understand, okay, this is something which is associated with these conditions and depletion is associated with certain other conditions. Now, there is no particular direct way to say that, okay, this is the specific neurochemical which is depleting here, or this is the specific neurochemical. It is a combination of multiple neurochemicals. So, for example, if I talk about depression, right, we attribute a lot of it to serotonin, right? But it is not just serotonin. We need to understand that there is norepinephrine, there is dopamine, there is GABA, there is neurotransmitters other than these, which play a role in probably causing that crux of biological cause of depression.
So let me ask you, is there a way to measure that you have an excess of a particular neurotransmitter and the depletion of another?
So there are tests which can be done, but they are more on the basis of research related work. They cannot be used in clinical practice. They would not give us an idea. Like I said, that it's a combination of multiple neurochemicals. So testing for a particular neurochemical would be more related with the research aspect of an illness and not the clinical condition or the clinical treatment.
So, Dr. Parikh, what makes you decide, I think this individual has come with a certain chemical imbalance and maybe say, deficit in serotonin?
The fact is that right now we are looking at a clinical diagnosis, and there is no other way to look at it. I will look at symptoms. I will look at the past history. I will look at my own, I will value the observations also. I will look at this conversation. Based on the nature of illness, I will also look at what the guardian, family member, caregiver are telling me based on the individual. I will look at all those aspects. I look at the functionality, the impairment of functioning. I look at the social functioning, occupational or academic functioning. I look at the individual's basic biological functioning or physiological functioning. We look at all of that. Let's be also very clear, there are well-defined diagnostic criteria also. So it's not that if you meet Dr. Shambhavi, she will have a different criteria and I will have a different criteria, or somebody living in the other part of the world will have a different criteria. Everybody is going to be using the same criteria for diagnosis. And by and large, the treatments are going to be very similar wherever you go across the globe. So one needs to understand that aspect also. The other thing, when Shambhavi was talking about the tests, we understand that there's an imbalance of neurotransmitters happening. Right. Yes, there is research happening to see if we can look at a quantifiable measurement for this, which will only help both in understanding treatment, understanding for the society. Sometimes when you see something so quantifiably and objectively, you are able to take away some of the other explanations that have been hovering around the science of mental health, right? So that's an evolution that is very much in process. But if you were to ask me that today, here and now, would I ask you to do any test that will help me judge that A or B particular neurotransmitter and that result would actually help my treatment, so on and so forth? Right now, the answer is no. And I'd like to believe that when we do a conversation on this in the near future, this will be different.
The reason why I asked this question also, a chemical imbalance that we talk about in the brain, could it be something more serious which has physical implications? It could be a more serious illness that may show up as a chemical imbalance. So you treat that person for depression, whether it's anxiety, and actually it is just the tip of the iceberg. It's happened.
I mean, before Shambhavi answers this, I'll put this in a perspective, right? So let's look at any illness for that matter. You look at a common illness like diabetes, and now you look at the comorbidity of diabetes and depression. if you were to take X number of people with diabetes and take a random population that similarly, which does not have diabetes, then depression would be more in patients with diabetes. So surely there is something that's happening there, right? So, which is why it is so important to look at mental ailments from the medical lens, that there is comorbidity and we wouldn't know what came first. For example, hypothyroidism. Hypothyroidism and the correlation with depression. In fact, levels of vitamin B12 and feeling of fatigue and depressive features. These are some of the common ones that one can talk about, which have an impact on moods, thoughts. If you even add, let's say, substances. So there are substances which if you take, you may experience psychotic features, which means you may experience certain sensations, visualizations, some other aspect, you may experience agitation. So the fact that biology, chemicals, behavior, social, or the body's reaction, they will all have a part to play.
I think I would add in the sense that Dr. Parikh is completely right in saying that a lot of times we do tend to focus on the medical aspect too much or the mental health aspect too much. I think both of them need to be in our mind when we are talking to anyone. It need not be that it's only depression. There could be an underlying factor with regards to a physical health illness, which we could be missing. So it's always important to, it should be a 360-degree vision when we are looking at any particular illness, be it mental illness or be it a physical health illness.
I know you talk about evidence-based treatments, right? And you've spoken to us about it in the past as well. However, there is also this question that keeps coming up, is that what may work for one person may not be true for the other person. So is it a protocol that you follow across?
No, but let's say you were not asking this question to Shambhavi or me. We are psychiatrists. Let's say this question was to somebody practicing the treatment of diabetes, somebody practicing the treatment in the cardiac sciences. This could have been a neurophysician or neurosurgeon. I can just go on and on. What would have been the answer?
They do follow evidence-based protocols, yes?
Yes, psychiatry is a science. It's a medical science. Medical doctors sitting in medical hospitals.
But doc, there's still a difference in medication. Like one person could come to you and get medication which is different, would go to another person, get medication which would be slightly different.
Again, I will answer the same way. You could go to two different cardiologists who may prescribe you two different antihypertensives, and both of them may be the correct answers because both of them would be a part of the guideline. But that's my way to look at it. We always look at the younger ones who are more qualified. So
younger ones who are more qualified.
My teacher told me that, Shri, my teacher, Dr. Bharat Panchal sir, he told me very clearly the most qualified person in any room is the junior most in the room because they have passed the exam just now. I mean, that doesn't apply to Shambhavi because that's like a couple of decades back. It's a fact. I mean, there's no point running away from it. You read more, you're exposed to more.
More well-versed in current techniques, perhaps. No, one of the points that I want to make here is that you've got to trust whichever doctor you're going to and stay the course. Literally, I say this to everybody across the board. Please stay the course and then take a decision to have a second opinion, because you cannot do that 2 weeks or 3 weeks into the medication and expect it to work wonders. And when it doesn't, you change doctors and then the whole thing starts again.
Two things. I mean, one, it is very, very, very natural and human to be able to feel a bit uncomfortable, restless, distressed when you don't see improvement. We all want to be relieved from the distress we are experiencing, emotional or physical. It'll always be there. I think it's also two-sided. So we'll also need to make sure that we're able to explain the timeline, the expected improvement and other aspects. It's absolutely fine if you want to take more opinions. To me, the key aspect here is just make sure you take the complete treatment and take the treatment. Just because you did not feel the best when you met A, that doesn't mean that that'll be with B, C, or D, because truth of the matter is treatment would still be needed. It'll still have virtually the same principles and approach, and human variance will be there, but course of the treatment is important. Whoever you are with, that doesn't matter. You need to get fine. if you go by the statistics, 8 on 10 times, you'll do very well if you are taking treatment.
One of the questions that we've been constantly getting is that can depression and some other mental health issue come together? Whether it's depression and anxiety or depression or something else, would you both like to answer that question?
I think, yeah, definitely. There can be two, mental health conditions which can come together, especially with depression. Something which we see very, very commonly is anxiety. It can be a part of another completely different mood disorder as well, such as bipolar disorder. It can be a part of, when there is presence of something called as psychotic symptoms, where there are hallucinations, there are delusions. It can be part of many physical health conditions as well. But I completely agree that it is a possibility that it is present with multiple mental health conditions.
Doc, you want to add to that?
Two aspects. Diagnosis may be also evolving. So on day one may feel that the diagnosis is A, and 2-3 years down the lane, one may feel that the diagnosis needs to be slightly changed or sometimes totally changed, because that's the evolution aspect that may happen. Day one, you have a depressive illness. There is no other history, no other aspects. You start treating for depression, you get fine. Couple of months or years down the lane, you get a manic episode. Your diagnosis then was depression. Your diagnosis here becomes bipolar. That's the evolution aspect. And the other aspect is comorbidity is like for medical illnesses. Comorbidity is very much seen, as in medical illnesses and mental illnesses, or mental illnesses amongst themselves having comorbidities, so depression and anxiety, depression and OCD, and they need to be treated accordingly. Having A does not mean you can't have A and B both.
Could one medication counteract with the other medication that you're taking, or also lead to a second diagnosis?
Absolutely. There are times when, certain medicines which are being used for even physical health issues can lead to certain mental health conditions. For example, something which is used for tuberculosis can cause certain mental health conditions like psychosis or a mood disorder. And when you say that, a particular medication which is being given for a physical health condition can also increase the effect of something which is being given for a mental health condition if they're not, if there's an interaction which is not beneficial. So there can be an interaction which can cause the increase in the effect of the other medication. So we need to be very, very careful when we are talking about, taking multiple medications for multiple conditions.
You take detailed medical history for this reason. So if, let's say, you come to me today and you are also taking treatment from one or two other specialists, I would want to know what medications you are taking. So one would need, so drug-drug interaction would be there. So, and that's why I'm saying that you, like any other medical field, it'll be the case. So if, let's say, you were to be given a medication for epilepsy, and the doctor would know that you are also taking medication for, let's say, psychiatry, then they would probably want to see how much change they need to do or what med to use or not. And that will apply across the board, across the field of medical science.
Patients need to be more transparent with all the medication that they are on, especially psychiatric medicines. Even if they go to, say, a liver specialist or a heart specialist, they need to be open and transparent about what other medication they are taking. Now, I want to bring up stress, because chronic stress is something everybody in the workspace talks about. How does chronic stress impact brain chemistry? How do you start terming it as chronic? And what are the best ways to mitigate its effect? Not all stress is bad. I keep making a point of this. There are people who thrive in it, but there's some who don't. So, Shambhavi, I want you to take this first.
So stress, when you say that not all people have a problem with having stress, some people have a benefit with working with stress. So there is a eustress, which is the good stress, and there is a distress, which is the bad stress, right? So distress is the problem. And then when we talk about that, when there is constant distress, if it goes beyond 6 months, then we call it chronic, any sort of condition. It is not just for psychiatry, for any condition. Now, stress impacts our brain chemistry for sure. It impacts the level of development of certain areas of the brain, most importantly, something called as hippocampus, which is important for our memory. People who have been diagnosed with depression, and when their scans have been done to identify the brain structure for research, they have been seen to have smaller hippocampal areas. So that is the correlation as to how chronic stress can lead to something like, say, depression. What is the brain change which usually happens with chronic stress? And when it comes to mitigation, I think a lot of factors will come into play, but the basic thing would be a good lifestyle, diet, nutrition, and regular exercise. So that is the baseline what you need to do for mitigating stress.
Dr. Parikh, are you seeing in your practice more and more people coming in with this kind of chronic stress, which is leading to mental health issues?
I mean, how I see this is that acute stress has its own impact, a more here and now impact. If that kind of stress lasts, it's bound to have an impact on you in your physical health, on your mental health, on your body, on your relationships. It's going to have an impact. I mean, you don't need a professional, a mental health professional to tell you that. I mean, if you are in a pressure cooker situation for a very, very long time, it's going to have an impact on you. At the same time, of course, more people will talk about it. To me, it's not only about the fact that there is stress in individual's life, it's also about how soon we are able to resolve it. See, unresolved stress is the issue. And that's where, while lifestyle is exceptionally important, I also feel that psychotherapeutic intervention at the right time is also equally important. And it's not one or the other, it's both. So you do the best that you can do for your lifestyle, but if you are struggling with something, you need to talk to someone. And if, let's say, when you talk to someone and that person's not a mental health professional, and you are able to resolve your distress, resolve your stressful aspects, and you're able to have a high level of functionality without an impact of that, perfect. But let's say that's not happening, then you don't wait too long, talk to a mental health professional. These are trained individuals who are using evidence-based treatments as well. Psychotherapeutic approaches are as scientific as pharmacological approaches that, let's say, Dr. Shambhavi and I do when we prescribe medications. And this is also something that needs to be understood. That we are willing to talk a lot about lifestyle. We do talk about medications, but we also need to understand that psychotherapy also has its evidence, and how Shambhavi was explaining the aspect of stress and the biological aspect, psychotherapy and the biological aspect also is very much established.
Can you describe it in more detail? How can psychotherapy, for instance, help you alter brain chemistry?
So basically, what happens when somebody is experiencing stress is that their cortisol levels go up, right? And that is something which is managed by an axis in the body or the brain, which is called as the HPA axis, the hypothalamo-pituitary axis, right? So when we have stress, if we are able to develop good coping skills, right? If we are able to address that stress with changes in our thought processes, changes in how we look at it, the perspective, it sort of mitigates the amount of stress which we are feeling, thus reducing the cortisol release or the levels. And in turn, it helps with regulating your mood and helping you resolve the depressive symptoms.
Whether it is psychotherapy, whether it's just counseling, it's not just about talking. It does have a scientific basis. And that's why it's good to talk to your friends, your social groups. That's one thing. But to talk to an expert, this is what could happen. That you could actually see scientific based or evidence based effects on brain chemistry. Science, it's all science.
It's not a coffee table conversation. It's not two people watching an OTT platform and also chatting. It's not that, it's science. There is significant role of combined treatment. I don't see many options where the combined treatment would not be indicated. There is role of psychotherapy, and there is role of medication. I completely agree to the aspect of lifestyle. I do fundamentally believe that our social systems have a significant role to play. And if you put all these pieces together, that's how you'll be able to get the best results. It's not one thing at the cost of everything else and you'll have the results. That's not going to happen.
How effective is medication for restoring this chemical imbalance that we are talking about? And is it always necessary?
Yes, where indicated it is. You follow the evidence-based approaches. You give it where it is indicated. Not giving it is negligence. You give it where it is not indicated. That is a different form of negligence. You follow the guidelines. You do what is advised. You know where the efficacy lies. You know where the benefit to the individual lies. You just follow that. It's not personal discretion. It's a science.
So, how do you respond to people when they say that we want to be able to restore this chemical imbalance without medication? Is it even possible?
No, I don't think so that there is a replacement for medication. Yes, there can be other forms of treatment which can be done alongside. If we are to need medication, we are to need medication. We cannot replace it with a good lifestyle or even psychotherapeutic interventions.
Doc, I want to counter question here. The reason why I bring it up is across those Insta reels, you see alternate therapies being propounded for actually restoring chemical imbalance in the brain. I want you once and for all to tell us whether this is even possible.
Simple question. Why ask this only to a psychiatrist? Let's say Shambhavi was a cardiologist, a neurosurgeon, a neurophysician, a liver specialist, a respiratory expert. Would you have asked this question?
No.
Then the question doesn't apply. The answer will be the same by any medical practitioner. If a medication is being prescribed, is based on the evidence that is available at that moment in time, and the medication is approved by most approval bodies globally. That's how a medication is there. One is aware about its efficacy, its side effect profile, its effects, its impact on the individual. All of those aspects go into the picture. So now this could have been, let's say, a question to a cardiologist about a certain intervention, which may be good for the heart. And if I were to say that I solved the same thing by doing ABC, anecdotal, personal experiences that cannot be supported by actual replication on other individuals, will continue to be anecdotal experiences, which at best are it's just fantasy.
And I'll tell you why I asked this is because Insta Reels, God bless them, but they have a cure for diabetes and they have a cure for hypertension. And sometimes it makes me feel guilty about having medication for my hypertension. And I've often blamed, the kind of stress that I've faced for hypertension. It's always useful to get a doctor's opinion. And frankly, it hasn't, these alternate therapies have not worked for me. But there is always this thing at the back of your mind. Could you have opted for naturopathy, or whether it's Ayurveda, whether it's homeopathy? I mean, I remember speaking to an oncologist about this, and the oncologist openly said it. Give me an instance of somebody who is cured by alternate therapies. Give me one instance. I'm not even asking for 10.
Two aspects. One, just because you call it therapy doesn't become a therapy. And all therapies cannot be clubbed under alternate therapies. There are therapies which have their own evidence. I'm willing to accept the evidence where it is there. But just because I would claim that something worked for me, that means it will work for everyone else. That isn't true. That's where our sense of literacy, in terms of health literacy or medical literacy, in these modern day times where I constantly talk about media literacy, which could be a different conversation, because I do feel media literacy needs to become so integral in our system, because the kind of bombardment of messages that media keeps giving us from all across the board, we don't even know sometimes what could be the right source, what could be the wrong source. In recent times, if you look around yourself, you will realize some of the best minds have been swayed by a completely fake report or false information, and then they'll realize, oh, this wasn't true. And that's the question here. If, let's say, you and I were having a conversation on you mentioned cancer, on oncology, any and every answer I would have given should be thrown away in the dustbin without giving any meaning to it, because I have no clue about it. I'm not an expert in it. So if you were to ask me a question on oncology and I were to give you an answer, and somebody else is listening to it and are wanting to believe a non-expert speaking on an area where they have no expertise, that's the question you ask yourself. You go to a cricketer to ask about how will this pitch behave. You don't go to a badminton player to ask about cricket, and you don't ask the cricketer to comment on badminton. This is more complex. This is human body.
No, here I would like to also put the whole bunch of influencers that we have now, unfortunately, who espouse things without research. I want to make this a point over and over again. In mainstream media, at least our learning, and we have been in the media, was you have to keep your sources credible. Take credible sources to give you information rather than think of yourself as an expert and try and give advice. Let's shift the conversation to women. Now, would you agree that women undergo hormonal changes and sometimes even an imbalance during, say, puberty, when we get our periods, childbirth, and pre and post menopause? Does this also change brain chemistry, and therefore are women more susceptible to mental health issues?
Absolutely. There is evidence and there is research and the statistics which say that women are seen to have more mental health conditions. One aspect is definitely the aspect of hormonal changes during these periods of premenstrual cycle, the puberty, the pregnancy, the postpartum period, and the menopause. That is also related to the brain chemistry. The brain chemistry being that estrogen, which is the female hormone, is related to the synthesis of serotonin, which is an important hormone in, a lot of mental health conditions. And this is one example. So if the estrogen sort of fluctuates or there is an imbalance in the estrogen levels, which can be during pregnancy, postpartum period, menopause, it will definitely impact our mood. So a lot of people do experience, especially in the postpartum period, there can be postpartum blues where they will have the fluctuation, they will be able to sail through it, but they will have that fluctuation. It cannot be negated. Sometimes, because of various other reasons, there can be some other conditions which can also crop up in the postpartum period. And same goes for menopause as well. For example, say that, there is a person who has just delivered a baby and they start to experience difficulties with their mood. A lot of times we say that, this happens, it's a huge change, which is true. I'm not going to say that it's not true. But in probably the first week after the delivery, there is a significant decline in the amount of estrogen which happens. So say a person A has delivered a child, within the first week, there would be 95% decline in the amount of estrogen which was there in pregnancy. And we all know that during pregnancy, there is a rise in the estrogen and the progesterone levels. And because of this decline, one starts to experience a lot of times weepiness, one will have low mood, sleep disturbances, irritability, and these are symptoms which we need to be on the lookout for. We cannot be saying that it's okay, it happens, it'll get better. We need to take it into consideration because it could actually be a mental health condition which could be arising. And we see a lot of people coming with these conditions, but not everybody is able to get that support. Like I said, that the awareness about, it is a mental condition which can happen during this period, the postpartum period, which is a few weeks after a person delivers a child. They don't know that it can happen and it just goes undiagnosed.
And the same thing happens even pre and post menopause, right?
Same aspect will come in the menopausal period as well. So be it premenopausal, be it menopausal, there is a constant decline which we see in the estrogen levels. So, and obviously the body is also going through many other changes, right? Even in the menopausal phase. So decreased energy, again, feeling low, feeling more irritable, or, experiencing a lot of physical symptoms along with them as well. I think that also predisposes them to start experiencing mental health conditions.
I think this is an important point to make for women who think they are going through it, who are not sure whether they are. And it's just important to meet the doctor and let him or her decide. Anyway, I have to bring up the connection between chemical imbalance and suicide ideation. It's kind of explained a lot to many people.
I'll give you the clinical perspective in terms of some factors, and I'll let Shambhavi talk about the neurotransmitter aspect. But let's just look at from an illness point of view for a moment. If you look at death by suicide and correlation with untreated, partially treated, severe forms of depression, then you will find a correlation. Now, depression's correlation with its neurotransmitter imbalance is also established. So, what one is essentially saying is certain neurotransmitter that's having its functional impairment happening, which is causing depression. And in depression, you are seeing suicidal ideation and death by suicide. So, what this means here is that if I look at early identification, treatment, complete treatment of depression, then there would be a impact on suicide prevention as well. But it's also important to understand that whereas mental illnesses and the severity and fluctuations aspect, at times the episodic nature, the chronic nature of certain illnesses has its correlation with suicide and its ideation. There is also the other aspect which needs to be seen when it comes to suicide, the economic aspect, employment, and some of those aspects also. This is a complex subject which I don't think can be seen only from the medical lens. Having said that, there is enough in the medical lens to make a significant impact on prevention of suicide in terms of right intervention and maintained intervention, along with the kind of social support that is required.
And I think when we talk about, like Dr. Parikh mentioned, that the brain chemistry and the changes which one experiences, yes, most of them are related with depression, but even in other conditions where depression might not be the main diagnosis which the person has, the chemicals involved in somebody experiencing suicidal ideations can be low serotonin, like we all know, which happens majority of the times in depression, along with which there can be a significant amount of decline in the dopamine receptors as well in somebody experiencing suicidal ideations. Also, certain other neurochemicals, such as something which is an inhibitory neurochemical, such as GABA, it is also implicated in suicidal ideations coming up in individuals. So, the decreased amount of GABA usually leads to thoughts about suicidal ideations, also some aspects of impulsivity.
So let me ask you this. You brought up serotonin, dopamine, and GABA. Is there any other way for you to restore brain chemistry? Can diet, can exercise, mindfulness, can they be a solution?
They cannot be the solution by themselves. They can be something which can be an add-on thing to the treatment, which is evidence-based, which is pharmacotherapy and psychotherapy. Mindfulness is part of psychotherapy. It is something which can exist. Support recovery, yes.
Doc, you want to quickly add anything?
So I'll put it like this, quality of life that does have an impact. Having said that, a disease is a disease, and evidence-based treatments need to be at the core of helping the individual come out of it.
Let me throw this to both of you. Are there any latest scientific advancements in treating chemical imbalances without long-term medication?
So I do feel that there'll be a lot of changes that I see happening. I think pharmacogenomics is looking very promising. The pharma medicines, genomics, genes, and how they're helping. Shambhavi looks into this very closely, has been studying and writing papers on it. So she'll probably be the right person for this. I do feel the neuromodulation is going to have a significant impact. What started with rtms, we're looking at deep TMS. There are other forms of neuromodulations which right now are globally being looked into. I do feel that will have an impact. I do feel some looking at medications which may not necessarily be using the pathways that we've been using all these years, and using some other pathways may also play part. Shorter, more precise, more targeted medication will also be the case. I see AI playing a role in the interventions. I see virtual reality also coming in and helping a lot of aspects, especially when it comes to the cognitive, neurocognitive aspects. I do see some of these things happening. At the end of the day, this is a young science. The first medication came in 50s. So if you look at it from that angle, the science has done well for itself, but it still has a long way to go. And that's the evolution aspect. So yes, to answer your question, do you see changes happening? Do you see more things happening? Most definitely.
Pharmacogenomics. Tell us a little bit about that.
So basically, as the name suggests, like Dr. Parikh mentioned, pharma means drugs, right? And genomics is your DNA makeup. There is a connection as to how your genetic makeup will respond to a certain particular medication. What would be the drug response based on your genetic makeup? So
How do you measure that?
it can be done by various modalities like a blood test or a swab test. It is something which is focusing on your DNA matter to understand that what are the genes which are prominent in you, which genes are associated with what enzymes, and those enzymes related to the metabolism of the drugs which we are using. So when you get this done, it helps us in precision medicine is what we call it. It helps us understand that, okay, these are the set of drugs which will give us a better response than something else, and some medications which need to be completely avoided because of their effect not coming because of the genetic makeup of the person.
And is this something that you do in your day-to-day practice now?
Yes, it is being used widely by individuals, by psychiatrists to understand, not just psychiatrists, it covers all the medical fields. So it covers all the other branches as well. But it is being used, yes.
In oncosciences, the genetic component, the pharma genetics has been used and established now and becoming more and more there. So if you look at it from that angle, then it applies, like Shambhavi was saying, not just for psychiatry, but other aspects as well. Psychiatry also because of various factors, one being the fact that you have a chronic, the tendency of a chronic problem, the fact that you may need to look at medications which you start on day one, by about 20-25 days, you may feel this may not be working and you change. So some of that can be impacted by pharmacogenomics. I think it's promising, quite promising.
Now, you mentioned rtms and dtms. Tell us a little bit about this.
So rtms is repetitive transcranial magnetic stimulation. It is a neuromodulation intervention. It is increasingly being incorporated in the treatment of mental health conditions like depression, like OCD, auditory hallucinations. So what it does is that it basically helps stimulate or inhibit certain areas of the brain, right? For example, when we talk about, say, obsessive compulsive disorder, right? We would want to stimulate a certain area called as dorsolateral prefrontal cortex. So basically what it does is that there is a probe which is placed on the head. It targets that particular area. There is a specific placement which has to be done. So it should be done by a psychiatrist and it stimulates that area. So it has to be done repeatedly for the effect of the RTMS to come. And usually what we see is a significant amount of improvement in the individual who's undergoing RTMS.
So this is the way the coil functions. You don't feel anything. There is no invasive or electrical activity involved.
There's this immediate fear of something happening to the brain. Does this ensure safety?
Absolutely, it does, because it is something which does not have any long-term impact on, the brain or the brain chemistry in terms of a negative impact. A person can come in, do the RTMS session, and then go about their day. So it's not that they have to be admitted within the hospital, be under observation. Nothing like that is required for RTMS.
Okay, and you are seeing a positive impact of this on your patients?
Yes, we have been seeing that. DTMS is a newer form, which is again being incorporated at places, but it is something which goes much deeper than the RTMS. The effects are still being researched as to, we cannot say that one is better than the others. It does have its own implications. Like I said, that it is in evolution and it is being used.
Do you think it would be cost effective to anybody who's coming in as a patient, say for instance with OCD?
You need to see it in totality. So if I'm sending you for a therapist, I'm putting you on some medications, I am asking you to go to RTMS, it's going to be used because it is indicated. When it comes to accessibility, the problem is that accessibility continues to be an issue. We are talking about the part of the world where experts are not as much as what is required. Low and middle income countries have about 1 to 2 per lakh psychiatrists as compared to 70 in high income countries. So when you have the clinician only less, and then some of those clinicians are also using some of these other let's say, techniques like Shambhavi mentioned, rtms, so that's even lesser. So naturally it's going to have its own part. But if you were to say that is it cost effective, the answer would be anything which is effective and improves the quality of your life automatically becomes cost effective, because cost here is both in terms of the loss that happens because of the continuation of an illness, and how soon you get fine and be back on your highest level of functionality. And that's how any treatment needs to be looked at, be it a medication or be it psychotherapy or be it neuromodulation as and when indicated.
So, why aren't more and more people talking about RTMS and DTMS?
No, I think the context here would be people don't talk enough when it comes to psychiatry in any case. Just because you may be seeing more of psychiatry or mental health on your social media feed, that's not a dipstick into how the entire society is approaching the treatment component and the illness understanding of mental health. Mental health literacy is not where it should be. The other aspect is access to treatment, the stigma around treatment. Even today, globally, 75% of people who need help do not seek help. So when you are not seeking help because of external factors, and then there are these subsets of these help which are more newer, more recent, that has its own impact. The other aspect is, I think when we talk about healthcare as a community, my take on this has been very, very clear. I will always hold healthcare providers as being the first line of, let's say, people who will have to take the responsibility of ensuring mental health care in the society. There is no substitute. It will have to start with the healthcare providers. So if all healthcare providers do not have integrated mental health programs, and now that you have telemental health solutions available, if healthcare providers are not going to integrate mental health, psychiatry into the overall delivery of healthcare, of course, you will not talk about some of these newer advances. If you are going to focus on the advances of a handful of, let's say, specialties or subjects, which is all very important, I've never debated that. But how do you ensure that the communication of all other advances also reach? I do believe it will be the onus of the healthcare providers, the medical fraternity as well. And of course, for colleagues in media like you, have a role to play. All of this, I still see is an evolution aspect, especially when it comes to mental health. I don't think mental health sciences is given its due, from policy to funding to corporates, to workplace mental health, to schools, to healthcares, to medical fraternity. I just don't feel we treat it the way we should. I mean, you go for preventive health checkups. How do you call it a preventive health checkup if it's not having mental health? I dare anyone who does a preventive health checkup in the healthcare community to define health without putting mental health in the context of health and then defending a preventive health checkup that does not have mental health. You should call it a preventive physical health checkup. At least be honest when it comes to communication.
Wow. I love that you feel so strongly about it. I completely agree. This is where conversations like this may play a role in educating people about what's happening in this sector, and so much help coming their way. I have to ask you, when you talk about AI, how are you using AI?
How I see AI is, I have a dearth of experts. I have a population that needs help. Some of these need to reach the expert. Some of these can be helped by themselves. Some of these can be given psychological first aid and guidance, and that will be good enough. So both aspects can be taken care of. It can help me in screening, guidance, basic guidance, and that can be taken care by AI, especially for places like workplaces. I do feel AI supported mental health solutions is something that needs to be very seriously looked into. And like I said, I mean, you explore all possible innovations that can help maximum people. Nothing is going to be perfect. It'll continue to evolve. We'll continue to learn. The first medication that psychiatrists started to write for psychosis, probably a young colleague like Shambhavi has not written in her entire career. but I would have written it for several years. That's evolution. So just because I didn't have 30 years back the choice of the medication that Shambhavi has, that does not make me at that time ignorant or negligent. But if I wouldn't have used them, which at that time was the best solution for me, we wouldn't have been able to improvise on it today. And that's how I look at science. And that's how, even for like virtual reality, when I mentioned, I do feel that as we learn, and there is evidence, there are papers that the neurocognitive aspect, you talked about depression, so some of the aspects of neurocognition, your attention, your memory, your focus, the mental fatigue, some of these which go with some of these illnesses or medications, including not just psychiatry but other medical problems, then would virtual reality based neurocognitive retraining have a role. I see that also having its impact, and I see all of these innovations that we are seeing all around us in the tech world will support healthcare as well.
Shambhavi, you want to add to that?
No, I think we should be a lot more embracing of the newer advancements which are happening. I do feel that a lot of them will take us much further in helping with the intervention for mental health conditions.
My last question to both. Since we're talking about chemical imbalance, what can we do to ensure that we have a robust chemical system right here?
Not sure I can do much about it. What I can do is I can have my other parameters to the best that I can. So if I am going through a struggle, which is not in my control, I do have my other systems working to the best, and I go ahead and take the help at the right time so that I can be supported. And my other systems would be my lifestyle. It'll be my social support system, meaningful relationships. It'll be the quality of life that I have, the balances of my life, my me time, the mindfulness of living in this fast-paced, chaotic lifestyle that we are allowing ourselves to become a world with fewer notifications and less scrolling, and maybe more greens, which are not as artificial as the ones that you look behind me. Maybe better air with better AQIs. But to say that, can I do something which will prevent neurotransmitter imbalance in the future? Right now, I can't say that it's possible. Maybe a few years down the lane, when you and Shambhavi are doing this conversation long after me, then you may well have that solution.
You really think I'm that young, right? Doc, good. That's great. This is what makeup does. No, but what you're saying is you cannot prevent depression or these imbalances from happening. And therefore, I want people to hear this, that it's not your fault. If you are depressed, if you get anxiety, it is not your fault. Shambhavi, I'll leave you with the last word.
I think some things which we need to remember from this conversation are awareness, more narrative, and from credible sources around mental health, and embracing the fact that it is part of our health. Like Dr. Parikh said, that there's no health which can be defined without mental health, and that's what we need to remember.
Well, I want to end with what I said in the beginning. Depression, anxiety, chronic mood disorders, even mental illness is not your fault. Just like it's not someone's choice to get diabetes or hypertension. A question that I leave you all with: why then is there stigma around mental health or mental illness when it's not anyone's fault? Thank you both, Dr. Samir Parikh and Dr. Shambhavi, for joining us on Zen-Brain.
Pleasure always.